There's no title to this presentation, so hopefully this case to kick off today's talk will be a surprise. But so I just wanted to start off first with this case. And I was wondering if there's any cardiology residents that want to try to take a stab at this.
I mean, I'm happy to look at it.
Oh, thanks, Anna.
So you're presenting a parasternal long axis view, which is zoomed in. And we can appreciate that, you know, like as we look at sort of chamber size quantification, there's some prominence of the proximal aorta. This, like, you know, we need to go and do proper like measurements, but the sinotubular junction just looks quite large, and it looks somewhat, there's not like a great distinction between the sinus of Valsalva, the sinotubular junction, and like what we see of the more distal sort of aorta. So we wonder if there's a little bit of like, you know, I want to know if this is, so we'll measure and see if this is aneurysmal or if there's some other abnormality associated with that. Obviously, you know, you're going to show us additional images. We'll put color on. We'll see if there's any valvular pathology in terms of like regurgitant jet or anything like that that might be associated with this.
Absolutely. Just because you asked, we'll go to some color.
Thank you. So, so we can see that there is quite a prominent regurgitant jet. Like it looks like it extends quite. So like as you ran it, I'm just trying to see if it actually is hitting the anterior leaflet of the mitral valve. And sometimes when you do an M mode, you can appreciate that even more easily. But there is a large sort of regurgitant jet that we can appreciate on this image that we can try to quantify further in terms of like measuring like the vena contracta and like other things as well.
Absolutely. And just some more images. So obviously the MR talked about the enlarged chamber size. It's the aortic aorta. More images.
Thank you. So now you've presented a zoomed in parasternal short axis view in which we're looking at the valve. We can appreciate that it is tri-leaflet. All of the leaflets appear to be moving. There's like the more anterior leaflet, which I think is the right coronary cusp, like looks a little bright and slightly thick, but I think I'm overcalling that a little bit, to be honest. There's not like a ton of chunky calcification or abnormality associated with this valve, but we do see that there's a large central regurgitant jet that we can appreciate on this image.
Yeah, absolutely. We keep going down, just a couple more.
Great. So apical four-chamber view demonstrating, you know, what looks like so from the clips that you're showing, the lateral wall motion doesn't look to be as brisk, and like I don't appreciate the thickening as well as I would hope or expect, especially like the mid and apical sort of segments of that lateral wall. The left atrium appears to be enlarged, so we would do like on the parasternal long axis, we would have done a left atrial diameter, and we can also use this four-chamber view to do our volume, our left atrial volume index. But both atria appear prominent, but especially the left atrium, which appears enlarged.
Absolutely. And then last one here.
Terrific. So this looks like to be a zoomed in like three-chamber apical view. So apical three-chamber, which has been zoomed in to sort of better show the aortic valve. And it's showing that the jet is I think it's showing us the vena contracta just being very large, and I think it's also showing that, like, the question is the jet sort of centrally eccentric? I think based on the compilation of views that you showed us, it's predominantly central. And then the other question is, That's what I appreciate.
No,
I'm just, yeah, sorry. That's my.
And that was awesome. So, I mean, a lot of even the things that you mentioned, I had to learn for myself for the first time in the preparation of this presentation. So that's fantastic. But I mean, just to summarize, as Anna said, that you have this enlarged left ventricle. You definitely see it, and obviously without the numbers, of course, it's hard to know, as Anna mentioned. But you know, there's lots of that differentiation of the tubular junction. Ascending aorta looks big. The root looks big. Looks like almost there's a coaptation gaps within the aortic cusps. Left atrial enlargement in the, as we can even see up here, that's the LVEF is severely reduced. So kind of tying this all together, I mean, even with this, you could say this talk is about MR, but it's actually aortic regurgitation. So surprise, that's what the topic is today. And so hopefully I can try to convince you that aortic regurgitation is a little bit more than just blue and red jets. So in terms of the objectives today, just want to take a quick moment to review the anatomy of the aortic valve, and then moving from there, the classifications and mechanisms of aortic regurgitation, assessment of the severity of AR by echo, as well as some other potential imaging modalities, and then interventions, and then what we can do to try to treat the aortic insufficiency. So moving to the anatomy, so Anna kind of touched on all these things in our opening case, but the aortic valve is a semilunar valve, aortic position. In the normal case, it's made up of 3 cusps, the non-coronary cusp, right and left, naming being from where the right and left coronary ostia originate. When you look at kind of a cross-section of the view, you can kind of see these almost little fibrous ridges called lineae that kind of terminate in these little nodules called nodule of Arantius. And they come together in this fashion with hinge belly coapting together to kind of produce this peace symbol or Mercedes-Benz logo as a closed valve. So where you can see that the kind of the upper part of the cusps connect to the aorta, that's what defines the sinotubular junction. Sinus of Valsalva is essentially where the origins of the right and left coronary artery are. And then where the aorto-ventricular interface interact, you've created essentially a virtual annulus. Here. Sorry, I didn't realize you were... Sorry, I'm just going to close the door. Sorry about that. And then just here again, kind of another image to just show you that's kind of the combination of these things, the sinotubular junction, annulus, sinus Valsalva, or what's creating your aortic root. And I know that it's maybe a little bit hard to appreciate with kind of these lines, but there'll probably be a better image later on. But you can almost imagine that the valve itself ends up taking a bit of a crown appearance, especially as the hinge belly coming up to this coaptation zone. So it kind of ends up looking a little bit like a crown shape. Also important to understand the anatomy of just kind of local structures, as it can provide an idea of what's going on in the pathophysiology of your disease process, or some things to consider when you're trying to treat aortic insufficiency. So certain things which many of you have probably already heard, that just the close proximity of the non-coronary cusp to the AV node. So a couple of issues in maybe a diagnostic sense is why that's important is that if you had a disease process like infective endocarditis, had a aortic root abscess, that's where you can start to see conduction abnormalities, particularly AV block, PR prolongation. Also important too, that if there's a surgical repair of the valve, that there could be potential damage to the conduction system, or within TAVI procedures, that as the valve has been expanded, that you could compress the conduction system, possibly requiring a pacemaker. Other important structure to note is the membranous septum, which is the thinnest parts of the septum. So possibly in some surgical repairs, you can actually develop a septal defect. Also worth noting within this is the ostia of the right coronary artery and the left. And essentially that has to do even with positioning, particularly in TAVI, so that you don't obstruct the ostia of your coronary arteries during the TAVI procedure. That's obviously why there's a lot of pre-planning, particularly with CT. And then these are just some echo images to kind of show you some normals many of you have already seen. But again, you have that tri-leaflet aortic valve in the parasternal short axis. And this is what it looks like in the long axis. And of course, with some congenital abnormalities, always worth mentioning is that you can have unicuspid, bicuspid, and tricuspid and quadricuspid aortic valves. And this is important because it can cause not only potential regurgitant lesions, but also stenotic lesions. So trying to establish what the conformation of your aortic valve is always very important. And then also trying to understand the mechanism of your aortic insufficiency is also very important. So this is this takes from the Carpentier classifications of aortic regurgitation, but essentially in your type 1 and looking at type 1A, essentially defined as the loss or the dilation at the sinotubular junction. B is both the sinotubular junction as well as the sinus of Valsalva. And then C being that you have dilation of all three, the sinotubular junction, sinus of Valsalva, as well as dilation of the annulus at the ventricular aortic junction, which is essentially going to create a coaptation gap and cause your AR. D essentially is trying to depict perforation through one of the leaflets. Particularly, you're going to see this more prevalent in infective endocarditis. And then when looking at both type 2 and type 3, type 2 would be quite prominent with lots of AR was a prolapse of one of the leaflets. So you would expect to see quite a significant jet. And then type 3 is degenerative. So you can see the thickening of the aortic cusp and restriction of the leaflets causing that coaptation gap. You also have rheumatic disease. One of the other interesting things is that with type 1 and type 2, that they're more amenable to aortic valve repair, whereas type 3 almost or usually requires replacement as opposed to repair, but all may also require replacement. In terms of the etiology, there are many, but a good way to kind of think about it is whether or not it's related to the valve or the aorta. As we were reviewing in the anatomy, discussing this very, very close relationship. So you can imagine that if the aorta is dilated, you're going to create that same coaptation gap, or even if there's a primary issue with the valve itself. So in terms of the valvular etiologies, understand that configuration as we mentioned, but probably one of the most common leading to AR would be a bicuspid aortic valve, rheumatic in that type 3 degeneration, infecto endocarditis and myxomatous disease, autoimmune disease like lupus, rheumatoid arthritis, Behçet's, and ankylosing spondylitis, degenerative, which is essentially speaks more to kind of long-term calcification of the valve, and then iatrogenic. Sometimes it's us, whether it's a balloon valvuloplasty that can create this after you've tried to treat aortic stenosis, which is it's fallen a bit more out of fashion, but used in TAVI, and also radiation, whether to treat some thoracic cancers. Related to some of the aortic causes of aortic insufficiency, systemic hypertension being a very prevalent one, connective tissue diseases like Marfan's, Loeys-Dietz, Ehlers-Danlos, syphilitic aortitis, and syphilis there is definitely increasing in prevalence lately. Tachyarteritis, again, but immune conditions affecting the aorta itself, again, like ankylosing spondylitis and lupus. And then in some of the more acute situations to cause AR, always really important to think about aortic dissection and, of course, trauma, particularly deceleration injuries in motor vehicle accidents. And then sometimes it comes down to the fact that we actually are just not sure what's causing this. And then just looking at a bit of the epidemiology for this, in terms of the breakdown, relatively even, but aortic causes just being slightly more common at 54%. And again, it's kind of alluded to that the bicuspid valve being your culprit, that if there's congenital abnormality in the configuration, endocarditis, that's 17%, rheumatic 3%. And aortic causes, aortic dissection, 10%, which isn't insignificant. Connective tissue diseases, the aortitis that I mentioned, but that sometimes there's not really a clear cause for the aortic or aortic root dilatation at 34%, which is I thought was pretty surprising. This is just looking at some more just kind of examples of aortic regurgitation. The picture on the left, looking at a 5-chamber view, if you can believe, just at kind of looking at the different types of severity. You can see kind of trace aortic regurgitation here. Very different from the first case that we talked about, and definitely from the TE image on the right, where you can see almost kind of just wide open aortic regurgitation. So quite severe. And we spoke about a type 2 prolapse. So this is a good example of that. You can see the leaflet here has just prolapsed completely. And this is also, which we'll get to a bit later in discussing the severity of AR, but this would be quite severe. So you see wide open coaptation gap that never really closes. And then again, on the image on the right, you can also see that again. And here, massively dilated aorta and aortic root, you can actually see, which I think is a really cool image, is the dissection flap. It's kind of in the wind here. Huge coaptation gap with the aorta. So again, if I could stress one thing, new aortic insufficiency, always think about dissection. So this is a really neat image that was captured. So when talking about all this, it's hard to not bring up some flow volume loops, especially in terms of the pathophysiology of aortic insufficiency. So essentially, when you look at the box on the right, looking at the more normal pressure, the line here represents contractility of the left ventricle, and the pressures at the volume pressure interface. That's contractility of the left ventricle. Kind of the dotted line here on the bottom is your LV compliance, and particularly in a normal heart, you have end systole here, filling of the left ventricle to end diastole, isovolumetric contraction, ejection of the blood to an end systolic pressure, and then isovolumetric relaxation, and then completing the loop again. As you can imagine, in aortic regurgitation, a lot of regurgitation blood flow coming back, increasing your stroke volume, so which will increase your end diastolic volume, which is depicted here. And now what the LV tries to do is, especially when it comes to to increase its compliance, respond to that increase in volume with its contractility, which will increase its end systolic pressure. So, and this is in a heart where you're saying that the ejection fraction is normal. So you have a situation that is not only volume overload, but a pressure overload situation on the left ventricle. Now, what unfortunately happens over time is that you're constantly putting the left ventricle under a great deal of wall stress, volume overload, that eventually it's going to begin to fail. And the pressure volume loop on the right, see this line here, demonstrates contractility that's decreasing. So that's your left ventricular ejection fraction now creeping below 55%, unable to accommodate that large volume. However, you still have the same amount of regurgitated volume back. So what you start seeing is this increase in end systolic volume not being able to tolerate the same pressures. And then that stroke volume that you otherwise were trying to accommodate to maintain perfusion has decreased. And so particularly at this time, you would expect to see a lot more symptoms, as well as even low output or even shock states. So quite serious. Just another way to kind of look at this, if you're really against flow volume loops, but just in the chronic aortic regurgitation picture, kind of coming into this side with the volume overload, kind of the response, compliance, and contractility of the LV, increasing wall stress, pressure overload, volume overload, and with the two can essentially precipitate heart failure. Also worth mentioning is the loss of the diastolic pressure with aortic regurgitation, which can also lead to coronary perfusion, decreased oxygen supply, increasing demand because you're trying to hypertrophy that left ventricle to deal with the pressure and volume, increasing oxygen demand, and can essentially create symptoms of angina. But really, a lot of this comes down to the mismatch through our old Laplace law with insufficient wall thickness to deal with the high afterload condition as well as the increased preload condition. Oh, there we are. And then if I couldn't have been dramatic enough about the kind of the seriousness of this, is that the initial flow volume loops that you think, well, okay, the heart's amazing, it can accommodate this, but this is a study that was looking at actually in fairly young men, kind of mean age around 35, 36, about the development of symptoms, death, or LV dysfunction, and particularly with the looking at the variable of end systolic dimension. They found that as that end systolic dimension increased, you can look at the marked increase in even potentially mortality from less than 40, 0% per year, to when it's over 50, 19% per year, which is pretty shocking. And that even that this is a difference of, potentially even 10 millimeters, and that your mortalities jump from 0 to 20%. So it just kind of speaks to, how important that when you catch this, monitoring for symptoms and LV dysfunction become paramount. So here again, another way of looking at this is just the mortality. Again, 10%. The other study suggesting 20%, but kind of the general natural history of aortic insufficiency from severe regurgitation, LV begins to dilate, those volume loops we talked about, LV dysfunction symptoms, and then really quite precipitously dropping out, decreasing your survival. And then this, I think, is always the golden question of, how do we catch these people at the right time for surgery, and then make sure they're kind of not on this side of the curve. So just very, very quickly, just the signs and symptoms for us. Of course, heart failure being a big one. We spoke about the pathophysiology for angina, and even just fatigue and not feeling great, especially if your stroke volume has been compromised. And then also to note that bradycardia and symptoms can be brought up by profound bradycardia, because this is a regurgitation within diastole. So if you have prolonged diastole, that your amount of regurgitation, your regurgitant volume will be much higher, which can precipitate, again, heart failure. So things to look at in vitals, wide pulse pressures, and which is due to a decrease in your diastolic blood pressure. And just worth noting on exam, apex can be laterally displaced, especially from a volume overload perspective, hyperdynamic and palpable S3. In terms of the murmur itself, it's a decrescendo diastolic murmur that starts from 8-2, the aortic position. Interesting, this is more some buzzwords, Austin Flint murmurs, which is a diastolic rumble that's usually caused by the aortic jet hitting the anterior leaflet of the mitral valve. You may even hear this kind of slight ejection murmur, which is kind of the rapid stretch of the aorta, potentially a click. And then some of the numerous kind of physical signs of aortic insufficiency. Mustard sign, which is kind of the head bobbing, Muller sign, where you can see the uvula bounding. Again, that's just the high systolic, very low diastolics, that whipping. And Quincke's, which I've never seen, but it's interesting, capillary pulse station. So as we've gone all through that, really important, of course, is the assessment of severity. So that's what is going to really drive what your management decision is. But I just think a really good way of looking at it in all these echoes is to really kind of think every single time, and even goes for any valve, is, you know, what's the mechanism here is that's causing this regurgitation? What disease process could that be related to? Assessment of its severity, which we'll talk about now, and then what additional information that you can use to support your call of severity, as it will have implications on the management. Worth mentioning, also the anatomic structure of the valve is a flail coaptation gap, and acute versus chronic, which we'll talk about a little bit later. But essentially, with acute aortic regurgitation, you're not going to see that long-term remodeling of the LV. LV will typically be normal in size. And actually what Anna even mentioned with the M mode is that increased LV EDP. You can see premature closure of that mitral valve, which actually you can see in the beginning of that first case. So in terms of trying to get your assessment of severity, first things first, color flow Doppler. So typically the apical window is the most sensitive, but the parasternal long and short axis usually help more for the origin of the jet. It can be better characterized and seen. And the big things that you're going to be looking for with color flow Doppler are flow convergence, vena contracta, and the jet area. So first, we'll talk about the jet width, the LVOT. Worth mentioning is that you can see just a very, very long jet. And and a lot of, I should mention, a lot of these markers of severity are from the 2017 ASC guidelines. They do mention looking at the jet length, sometimes it can be quite stark, but they do say, you know, use this with caution. It can be unreliable because it's very dependent on driving pressures. So moving to jet width, so you're looking at the width of the jet within the LVOT. So you're looking at the central jet compared to LVOT diameter, and essentially if it's occupying more than 65% of the LVOT, that's more consistent with severe aortic regurgitation. Similar process in the short axis, but of course, if you have multiple jets or an eccentric jet, this kind of falls apart. So that this is used more of a supportive criteria as opposed to diagnostic. So vena contracta, and then in this image here on the right actually shows kind of all three that we'll talk about, but jet height being here. Vena contracta, so best seen in the parasternal long axis. And essentially you're looking at the narrowest part of the jet, or the neck, which is kind of better even seen in this image. And the idea is that you're going to measure that. Less than 0.3 centimeters, more consistent with mild. And if it's over 0.6 centimeters, more consistent with severe. Advantages to measuring the vena contracta is it's a surrogate for regurgitant orifice. It can be used with eccentric jets, less dependent on technical factors, easier to see. And then it's less dependent on flow rates and driving pressures, which is a problem with the jet length. But again, ends up kind of falling a little bit with multiple jets. And then of course, that just from a technical perspective is that if you can't visualize it, it'll be very difficult to measure. Also, you really want to make sure that you find the neck and kind of search for that good image, because I mean, as you can see, that they're not great distances to be off. So it's just important to really kind of find the narrowest area of the jet. So in terms of flow convergence and talking about PISA, it's important to talk a little bit about fluid dynamics. So essentially, with fluid dynamics, as fluid is approaching a regurgitant orifice, just like here, essentially what it does is it ends up forming these kind of concentric shells that, as it approaches the orifice ends up sharing a isovelocity at that distance from the orifice. So essentially this is taking advantage of an echo to determine essentially a piece of the continuity equation, because you understand the velocities and the area kind of this shell. which you can solve hopefully for the area here. So essentially what you do is you adjust your Nyquist limit to determine what the velocity at your aliasing boundary will be. So kind of in the example here, what will happen is that if you drop your Nyquist limit here, you know that at this shell, what's above will be blue, and the shell itself will be red or yellow. And essentially you want to try to measure the distance from the orifice to that shell, which you'll know the velocity. And as it's a shell, essentially using the formula of 2 pi r squared, you'll know your aliasing velocity, and that's essentially what you're going to be solving for with kind of the top of your continuity equation. And then you're going to essentially do a continuous wave Doppler and determine the peak velocity through the valve, and then solve for the EROA. And essentially and this is more of a quantitative method, determine the EROA, and if it's over 0.3 centimeters squared, that's consistent with severe. Typically with the Nyquist limit, you want to aim for it to be about 30 to 40 centimeters per second. Best views, peristernal or apical, wherever you're seeing it best. And also too, when you're determining the peak velocity of regurgitation, also typically you want to measure the VTI. Where that's going to be helpful after you solve for the EROA, you can multiply that by the VTI to determine the regurgitant volume. Volumes over 60 mils are consistent with severe aortic regurgitation. And then regurgitant fraction, essentially you're just subtracting the stroke volume from aortic valve, mitral valve, and dividing by the aortic valve. And over 50% is consistent with severe. Another way just to quickly solve for regurgitant volume, essentially in a normal situation, the stroke volume out of the LVOT should be equal to the stroke volume that's entered through the mitral valve. So if there's any difference, that there must be a regurgitant flow or volume. And so essentially by subtracting the LVOT stroke volume by the mitral valve stroke volume will give what your regurgitant volume is. So just another way of trying to help solve for that. Other things with the continuous wave Doppler. So again, really just the bottom line is the best windows that you can kind of see it, but apical, sometimes peristernal, if it's eccentric. Signal density, because I always talk about of the envelope being more dense, can reflect actually volume of the regurgitation. And essentially just some more of, again, kind of supportive criteria, but if it's faint or incomplete, that would lead you to think that, maybe this regurgitation is mild to moderate. But if it's really dense, it's more supportive severe. But again, the ASC cautions you saying that you wouldn't be able to differentiate between moderate and severe. The other thing is, if you look at the image up here, pressure half time, so measuring the slope from the peak and its slope down deceleration. So if the pressure half times over 500 milliseconds, more consistent with mild, 200 to 500 moderate, less than 200 milliseconds severe. Again, just some caution is that typically this can be affected by compliance LV. So severe diastolic dysfunction can have short pressure half times. Then also, if you end up treating your aortic insufficiency with vasodilators, that's you can actually have higher pressure half times. So essentially saying that it's less severe, but you're treating the aortic stenosis or the aortic insufficiency. Sorry. Pulse wave Doppler is particularly used to look at diastolic flow reversal within the descending aorta. So essentially what you're going to do for this is in the suprasternal window, put PW at the descending aorta, and you're looking for flow reversal. Worth mentioning is that early diastolic flow reversal can be normal, but if you see hollow diastolic flow reversal, that's consistent with at least moderate aortic regurgitation. If you're ever seeing flow reversal in the abdominal aorta when you're looking in the subcostal views, that should lead you to think that this is severe. Worth mentioning is that it does come with a pretty big differential that's worth thinking about. So if you do see it, it could be because there's a presence of a left or right shunt through a PDA. There's reduced compliance in older adults' aortas, upper limb AV fistulas, dissection with flow into the false lumen, or ruptured sinus of Valsalva. So also worth mentioning is that you may not actually see it become holosystolic in acute severe aortic regurgitation or severe bradycardia due to equalization of the pressures. And you can kind of see this flow reversal depicted in diastolic here, hollow diastolic. So some other modalities that you can look to try to figure out what's going on include TEE. So really what the indication is making you want to do this, if you really require more detailed assessment of the morphology of the valve, the mechanism of the insufficiency is unclear. Maybe, you know, there's a history consistent with infective endocarditis. It's going to push you to look for this. Measurement of flow parameters, and of course pre-surgical planning. But I mean, this should really definitely reach for this, especially if the clinical or physical exam are out of keeping with your TTE, you may want to consider moving to a TEE sooner. Also, the ASC brings up cardiac MRI. Again, mechanism quantification. For aortopathy, it's quite good, especially performing an MRA. And then detailed assessments of LV remodeling. So the indications where they say that, you know, maybe you want to make a referral to cardiac MRI would be suboptimal echo images, discordance between LV enlargement and Doppler severity, discordance between the clinical assessment and your echo, which you mentioned before, moderate to severe AR suboptimal chamber quantification, which is pretty self-explanatory, and then just for more detailed assessment of the aortic root, particularly in those who suffer from or who have a bicuspid aortic valve. So these are cine images from a cardiac MRI. Unfortunately, I couldn't get them to move, but what you can see here is you can see this little kind of black jet here and here. That's actually the aortic regurgitation. And even this jet, you can see actually hitting and bouncing off the anterior mitral leaflet. And then just a massively dilated aorta. And this is almost even consistent with pretty much like dissection. So just kind of bringing this all together in that long-winded statement, I would just look up this table if you've already forgotten what I've mentioned. But essentially, you're really looking at this severe column. Again, these features that are supportive, and then your quantitative parameters below, really important. EROA of greater than 0.3, regurgitation fraction over 50%, and regurgitation volume over 60. And now, when you're trying to decide, you know, how do I put all of these things together to really call it severe? Just further down in the guidelines, they do mention that, give you a little bit of an algorithm to kind of help you with that. Especially the ones that you're like, well, I'm not sure if it's been completely validated. So the specific criteria, they say that if you can meet any of these and you have greater than 4 fitting in this column, which include flail valve, pressure half time, holosystolic and descending aorta, you can fit 4, you can go and call that severe AR. If you've met 2 to 3, they really kind of push you to say that, well, you know, you should take the time to do some more quantitative measurements. And then at that point, you're going to be looking into essentially doing your PISA to get your volumes and regurgitant orifice. A lot of the time, you'll do that anyways. And then, of course, there can also be some gray area where you're going to look at using these supportive features to kind of make that diagnosis of severe. And then, as we already spoke about, if this is still not kind of making sense, always consider further imaging with TE or cardiac MRI. So once when you made the diagnosis, of course, based off a little more self-explanatory, that you're going to follow up much more closely if you're seeing, if you have more severe aortic insufficiency. So with this severe, the recommendation to see about every 6 to 12 months, probably even closer. Because again, if you remember that curve that I showed earlier, that it's really important to kind of catch on that curve before there's, very severe dilation or very severe decrease in LV function. So you're going to follow that closer. In terms of just the basic medical management, education ends up becoming really important. And again, I know it kind of sounds like a broken record, but symptoms and catching those symptoms, very important. So just to advise your patient to be on the lookout for signs of heart failure or angina. Avoid strenuous exercise, particularly isometric exercise, as you essentially just be increasing your preload, worsening the regurgitation. Treating diastolic hypertension, important, could consider the use of ACE inhibitors, treating afterload, and avoidance of bradycardia, really avoiding use of beta blockers in this situation. And now in the more acute situation, what's really important, really definitive, will be surgery, but trying to get them to surgery. Positive ionotropic support with dobutamine is recommended. Also give you beta agonist, preventing bradycardia, and then to deal with afterload, nitroprusside. And then of course, with all this, really worth mentioning, diuretics, incredibly important. Because again, as I'm talking about the pathophysiology, both a pressure and volume overload condition. So there has been a bit more of a recent update in the aortic valve surgical guidelines. So the last published in 2014, but the AHA and ACC came out with these new recommendations with just some minor changes that we'll just try to highlight. Mostly in terms of the diagnosis of severe AR, they've kept it all the same, although they did take out a line that just said L enlargement. Didn't provide really, I mean, they provide most of the numbers down here, but it's more of this quantitative assessment that you're looking for, with some supportive features with the Vena contracta and flow reversal. Essentially, it remains the same, that if you're severe AR and symptomatic, class 1 indication to go for aortic valve repair replacement. Asymptomatic, the biggest change is that actually this used to be an LVF less than 50%, now 55%. I think just highlighting the importance that you're really not going to, once we start losing those percentages of ejection fraction, that the course ends up accelerating quite exponentially. So just trying to catch people faster. And of course, if they're already in there and they can do something, other cardiac surgery. In terms of the volumes, end systolic diameter over 50, that's where we started to see in that, especially in that one trial, that mortality jumped to about 19%. So important for chamber quantification, watch those volumes. And then they've just added this index score also to consider. There used to be a whole bunch of kind of breaking down the difference between 50 and 60 millimeters between chamber sizes, but essentially they've consolidated this and said just be on the lookout for kind of progressive decrease in LVF, as it may actually be hyperdynamic before, but once you see it decreasing with a very enlarged ventricle over time through studies, that you want to consider intervening on that sooner. And so the other big thing just worth mentioning is that the use of TAVI is becoming really quite popular, especially in patients who are poor surgical candidates. But essentially, this is the first paper that was looking at back in 2013 about whether or not this would even work. And essentially, the graph on the left represents absent or present calcium within the aortic root, and showing that really this TAVI was actually the most successful, that if there was calcification existing in the root, whereas if there wasn't, that they actually required a second valve implantation. And on the right, just looking at NYHA class and seeing that there was some improvement of that. And as time's gone on, there have been studies looking at not necessarily the great numbers, but just whether or not that this was possible. Second valve implantation, procedural complications relatively low as operators have gotten better with kind of transcatheter replacement. Some good success, particularly, and a need for pacemaker not being too bad. And this was done in 2017. Interestingly, with this Jenna valve, there's ongoing research into its utility, and that it's I actually believe it has like ongoing clinical trials as we speak. So another potential option for your patients who are otherwise not surgical candidates for treatment of aortic insufficiency. Worth mentioning, just kind of bringing back to the first case. So recent case that came through the Echo Lab, go all the way back up, but ended up with all of these features that kind of just spoke about. Ended up having a EROA of 0.6, a regurgitation volume of 86 mils, decreased LVF at 25%, severe left atrial dilation at an index of 79. So kind of, and then aorta, I'm calling moderate root dilation, moderate ascending aorta dilation. It's kind of all in all fitting with this kind of very severe aortic insufficiency. So hopefully there's some tools there that you can use the next time that you kind of see these big jets. In terms of this patient, actually, surgeons wanted to take to replace the valve, but the issue, what the surgeon came to the Echo Lab to speak about was this patient ended up becoming pretty decompensated. In this case actually showed early mitral valve closure with EDP. So the decision was actually made to try to optimize as best medically before taking to the OR. You can see that it ends up becoming kind of ends up taking multiple teams to talk about, what's the best case to the approach of these patients. But hopefully now we can try to catch them earlier and then address the issue. But that's all I have. Thank you so much. And if there's any questions. Thanks.
So thank you, Jeff, for this very, very comprehensive review of aortic insufficiency. So this is actually remind me of a patient that we recently took care of on the ward. I think it was admitted, and we optimized him, and he will be seen at the heart failure clinic, and then double checking the systolic function before he will be considered for aortic valve replacement. So thank you. Just a few quick historical facts. Aortic insufficiency is probably associated with the most eponym that has ever been. Like we have to learn during medical school. So Dr. Austin Flynn is one person, and there's a Dimoussier sign that Jeff mentioned. That is a head bobbing. It's a name after a French poet, most likely with syphilitic aortic insufficiency. So anyway, open for comment and suggestion. This is one area that we deal with all the time, and also lots of measurements and so on and so forth. So any questions or comments from my colleagues?
Go ahead. Hey there. So when you see a very dilated aortic root, what's the indication to do additional imaging of the rest of the aorta?
Yeah.
When should we do a CT to look for stuff in the ascending aorta, descending aorta, whatever?
Yeah, I think so for that, I think that definitely from a kind of pre-surgical planning, I know that a lot of the surgeons always want to go in there knowing what the rest of the aorta looks like, and especially I've at least seen on limited exposure to cardiac CT rotation. They actually want CTA because you can actually see the dimensions of the aorta the best, measured at every level. I think including the descending aorta, I guess more so that if you have aortic disease, it's because the disease affects any other part of the vessel itself. Surgical planning, I think that's most, I don't know if annex, and you probably have more exposure to that, but that's just what I've seen in my very limited scope.
Thank you.
Jeff, it's Kim here. Great rounds, thank you. Obviously, the current guidelines use sort of linear dimensions. Did you see anything more about volumetric analyses as to sort of a guide as to when we might consider surgical planning?
I didn't, but is that kind of more of a shift now?
Yeah, look, you're absolutely correct. As you know, usually the guidelines are about 10 years behind where we are clinically. At the moment, though, we're still in the midst of sort of coming up with more robust studies with volumetric assessment, as opposed to being stuck with a linear, dimension. And as you mentioned, the sort of 50 millimeter, 70 millimeter cutoff for and systolic and end diastolic dimensions, or even the indexed ones. Geraldine published a nice paper from Mark Peterson's data set a number of years ago showing that volumetric assessment was basically a better predictor of who would reverse remodel after an aortic intervention. So I think just to sort of give you a heads up, that's where the literature is starting now to move towards, because of the limitations of a single linear dimension. And we know when the ventricle dilates, as you nicely showed, the reason why with the pressure volume loops, we know that as the ventricle dilates, it may not, it undergoes this eccentric dilatation and takes on a more circular shape at the apex. And then obviously it starts to then dilate in, if you will, in that AP plane. So that's actually quite a later phase in the remodeling process. So, hopefully by getting better volumetric analyses, that may then start to refine who might be an appropriate candidate for earlier intervention. And along with that, I think there's an increasing trend to use things like strain imaging to help us understand more subtle abnormalities in left ventricular systolic and diastolic function, to determine, well, who is that person who, in that, when you're making the decision, might then fail to reverse remodel in the way. Because as you're aware, like the case example you've got in here, we know that the surgical risk is much, much higher, because obviously once you go in there and correct and the issues are going on pump and so on, is another insult. And we know that volume loaded hearts do not respond the same as pressure loaded hearts there. So, that's where the literature is going. But as I said, we don't actually have the data as yet. And just to answer Anna's question, everyone who we want to then go for surgical intervention, when you think it's going to change the management, should get a CT or an MRI. Echo is not accurate enough because of the limitation with acoustic windows, as opposed to having a proper 3D reconstruction technique. Here, what we generally do is, if it's a younger person, we use MR because we avoid radiation. But if they've had CTs, then we generally use CTs in a sequential fashion, so that then we can monitor the progression, in particular of the aorta, and then use that for surgical planning. So pretty much everyone. And of course, it's the standard sort of criteria, obviously depending on the syndrome. If you've got someone who you've got Marfan's or Louis-Dietz, we're going to operate at a much lower threshold. So you might want to do the CT around the 40, 45 millimeter mark. If it's outside of that, then if you're seeing a significant increase of more than 0.5 millimeters, 0.5 centimeters per year, or you're getting around that 50 millimeter mark, then we'd for sure recommend you'd get a CT or MR in that setting to support the surgical planning there. And there is a bit of a difference between the measurements in the aorta. Just as you know, you tend to go from outer edge to outer edge, whereas we do measure it a bit differently. But Mark and the surgeons are pretty happy in sort of extrapolating what we've measured at the moment. But of course, we would recommend you get the CT or the MR as part of that process, along with, like you suggested, the TE, to help then understand, what the likelihood of repairability of the valve, and to avoid replacing the valve. So, that's absolutely part of the aortic evaluation, is looking at the aorta. Because remember, what often generates the aortic incompetence here is either dilatation at the sinotubular junction or at the aortic root. Dilatation at the sinus level does not then cause displacement of the aortic leaflets, and that won't generate central AR. So it's really all about the root and the sinotubular junction that will then lead to central AI. So if it's not central, then you've got to think about, well, is there another mechanism that has led to the aortic incompetence there? So, you know, and obviously this is where it's super important that we sit down and chat with the surgeon so that we can help appropriately plan. Great rounds though. Thank you.
Great. Thank you so much, Dr. Connolly.
Thank you.
It's Bob Howard. Just one quick follow-up comment, practical comment on what Kim just said. And looking at this particular image, the question is, for the linear dimension, where do you measure? You know, typically we measure at the tips of the mitral valve for end systolic diameter and diastolic diameter, but this heart is obviously globular. If you measure just more distal to that, you're going to get much bigger measurement. And I think, so today, while we're still doing linear measurements, you probably want to measure a little more distal than the normal spot to get something that's more reflective of LV size. So when you're comparing one to another, you got to go back and look at where they measured, because you're going to get different measurements depending on where you do that linear measurement. And this is a good example of why that might be.
That's great. Thanks so much, Dr. Howard, and thank you everyone for rounds today.